obviously you have spoken for that neuroprotection as present, we have not been able to translate it into clinical practice. But as you've already rightly mentioned, that neuroprotection and neurodegeneration is the main culprit which is there in glaucoma, and retinal ganglion cells are dying in front of us. And IOP lowering itself does not protect and prevent this degenerative process, because there's damage which is occurring not only in the pathways of the survival pathways of the retinal ganglion cells, but it also there are various triggers which are happening and which are causing apoptosis to these cells. So as you've already rightly mentioned, that elevated IOP as well as the ischemic damage is there, which is ultimately causing this retinal ganglion cell apoptosis. But neuroprotection is definitely an approach which we have to adapt. Why? Because even if you look at the currently available AGMs or the anti-glaucoma medications which we have, they have some improvement in the ocular blood flow, especially the brimonidine and the prostaglandins and even dorzolamide. They are decreasing resistive index of your posterior ciliary circulation as well as in the ophthalmic artery, and that is having a protective effect to your nerve. So next generation of therapeutics, which we are, the studies which are happening at the stage of clinical trials are going on at different levels in US and in other parts of the world, are what they're targeting is the survival of the RGCs as well as rebuilding the neuroconnections as well as something called as neuron enhancement. As you said, rightly said, there's a list of medications targeting different strategies and different ways they have to work and to work for neuroprotection. And there are multiple clinical trials which have been done and are in the phase 2, phase 3 of clinical trials, especially related to brimonidine, whose role has been, I'll be mentioning about the study which is related to that, which has shown that obviously besides its IOP lowering effect, it has a separate effect on neuroprotection. Similarly, memantine, I would say, obviously I agree, did not translate into the trial results were not positive, but we have the stem cell transplantations and the mesenchymal which have been done for the NAION, and they have shown positive results. And similar trials are going on for the patients with glaucoma. And same is for gene therapies, which have shown positive and good results for patients with LHON, and these similar trials are going on for patients with POGs. So neuroprotection with topical medications, as I already mentioned, for brimonidine, it is well established by various studies, although they are animal studies. But obviously one of the studies, which is the LOGATS studies, which was a randomized double-masked clinical trial done in Singapore, which showed that elevated neuroprotective effect of brimonidine was found to be much more than that of the timolol. It was 9% versus 30% for the timolol, and the assessment outcome measure which we had assessed was the field progression, and this was dramatically less. Field progression was seen with the use of brimonidine as compared to timolol, and this findings were further reiterated by DeMorais et al., who found that this neuroprotective effect of brimonidine is unrelated to IOP lowering effect, and neither it is related to changes in the ocular perfusion pressure. So current approaches to neuroprotection which are being targeted now are strategies to improve the optic nerve perfusion, rescuing the damaged retinal ganglion cells and the optic nerve regenerations. And so we have the ROCK inhibitors which are being tried for this in the form of topical applications and intravitreals, the centrally acting calcium channel block inhibitors, and also by use of flunarizine, which tends to increase the aqueous outflow as well as acts as an NMDA antagonist. While neurotrophins are the ones which are being used for rescuing the damaged RGCs by application of various neurotrophic factors by exogenous means, and also strategies are being adopted to inject them intravitreally as well as intracamerally, and transplantation of these to the retina. And genetic engineering studies are going on for reactivation of these receptors. One of these is the Renex's NT501, which is under trial in US at present, which is injected into the pars plana and stays there throughout life, and has undergone phase 2 trials for other retinal degenerative conditions like retinitis pigmentosa and MACTELs, and has given positive results for that. And currently it is under trials for primary open glaucomas as well. While for optic nerve regeneration, we have various strategies to block the inhibitory signals, enhance the intrinsic growth, and stem cell transplantations, and which have again, ROCK inhibitors is one of the groups which is being used under trials for this, and the NOGO or the oligonucleotide-derived proteins are being used. And for enhancing the intrinsic growth ability, again, we have the CNTF-based growth factors, which are being given as viral transcription factors. And finally, the stem cell translations for enhancing the survival of the RGCs.
Thank you so much, Dr. Vinita. That was indeed a wonderful presentation, and by both the speakers.
In the end, I'll just need to conclude that this DART which has come up, that is going to be a useful thing for translating, because what is the problem which is happening with the trials on neuroprotection? They are very long trials, because obviously the disease per se, glaucoma, to give results as clinical translation of the clinical effect, as visual field effects or something to pick up in that, the dark has an advantage on that. So dark is going to be a technology which will help in picking up the apoptosis of the RGCs at an earlier stage.
So let's
if we-
see that whether our
if we are
panelists have agreed to it or
incorporate
not.
that,
So I will
so-
request Dr. Shiraj to throw some light on neuroprotection.
Neuroprotection in glaucoma is no doubt full of promise, but clinically proved strategies have remained elusive. So it should be an active area of research, but one good advantage of neuroprotection in glaucoma is that it targets the common final pathway of neuronal loss at the level of RGC and axonal projections, irrespective of the mechanism of glaucomatous optic nerve head damage. So for me, it's still a mirage.
So for me, in my practice, for all patients of glaucoma, in the terms of neuroprotection, I would like to advise them meditation. I don't know how much all these micronutrients work, but definitely meditation has already shown proven benefits in neurodegenerative diseases like Alzheimer's, and a good body of work has already been done at RP Center, which shows very good effect. So I think it is something non-invasive, patient doesn't have to buy, it doesn't cost. So irrespective of anything, we should advise meditation to all our glaucoma patients. It will be good for overall well-being of them in addition to IOP lowering.
So yes, ma'am.
One is for the comprehensive ophthalmologist is the best neuroprotection is lowering intraocular pressure. That is one thing. Second is the study which Dr. Vinita mentioned, where brimonidine has a neuroprotective effect, and that is one point which has been sold by the pharma companies to all the comprehensive ophthalmologists. So when a patient, when I asked, why did you not start him on PG analogs? No, brimonidine also has a neuroprotective effect, and that's why I started. That's not the thing. As I said, the first thing is reduce IOP is a best neuroprotection. So don't use these topical medications because of their neuroprotective effect. So this is one point. Yeah, this is just one point I wanted to get across to the comprehensive ophthalmologist.
So I think we are very loud and clear in conveying a message that neuroprotection has a role in when it comes to glaucoma treatment, but only after lowering the pressure when nothing is working. Then that is the last resort with you left. Else, don't try the neuroprotective drugs topically before starting anything ahead further. So thank you very much, Dr. Vinita.